Now that we've discussed our approach to NAGMA and we arrived at a working diagnosis of RTA for our case, let's now understand the subtypes of RTA just to better understand what's going on with our patient SID. We learned that the major functions of the kidneys in acid-base homeostasis are to excrete hydrogen ions and reabsorb bicarbonate. Failure to perform these functions results in bicarbonate wasting or diminished acid secretion, leading to renal tubular acidosis, or RTA. It's a NAGMA, as we mentioned before, and it's hyperchloremic metabolic acidosis, and it occurs in the presence of a relatively preserved GFR. The precise pathophysiological mechanism underlying the disorder varies across RTA subtypes. So we have distal or type 1, proximal or type 2, and hyperkalemic or type 4 RTA. Type 3 exists, but it's very rare and won't be discussed. I know there's a lot of nomenclature involved here, so here's a mnemonic to help you remember them. D becomes before P in the alphabet, so type 1 is distal and type 2 is proximal. But to simplify, I'm only going to be using the terms distal, proximal, and type 4 moving forward. In children, RTA is due to either an inherited or acquired defect that affects the kidney's ability to absorb filtered bicarbonate or excrete ammonia or titratable acid. Let's start by talking about proximal RTA. So proximal RTA is caused by a reduction in proximal bicarbonate reabsorption, so naturally we get a fall in the plasma bicarbonate. In this case, our distal convoluted tubule is functioning just fine, so our urine is being acidified normally. So urine pH is likely normal in this case. Proximal RTA can be either an isolated tubular defect, but more commonly we see it as a component of a generalized proximal tubular loss called Fanconi syndrome. Same name alert, this is different from Fanconi anemia, which is a hematological disorder. So Fanconi syndrome is characterized by proximal RTA and thus inappropriate loss of bicarbonate, phosphaturia, renal glucosuria with a normal plasma glucose concentration, aminoaciduria, and tubular proteinuria. Causes for Fanconi syndrome can be either genetic or acquired. Acquired causes include heavy metals and medications such as aminoglycosides, cisplatin, and valproic acid. Several genetic causes of Fanconi appear during infancy, with infantile form of cystinosis being the most common. And cystinosis is a lysosomal storage disorder that is characterized by accumulation of cysteine in all of the organs, which leads to dysfunction of the PCT cells. Proximal RTA can also occur as a transient developmental problem in neonates. Commonly, term infants have a normal mild RTA with serum bicarb concentrations of about 20 to 24 millimoles per liter, and preterm infants can have values as low as 15 millimoles per liter. This is just a transient abnormality of bicarbonate resorption that improves progressively during infancy. Let's move on and discuss distal RTA. So distal RTA involves impaired distal acid secretion that results in an inability to excrete the daily acid load. This progressive hydrogen ion retention leads to a fall in plasma bicarbonate concentration that is accompanied by an abnormally high urine pH. So our urine pH is going to be greater than 5.5. The etiology for type 1 RTA can again be genetic or acquired. Genetic primary causes of distal RTA are usually mutations of genes that directly affect membrane transport proteins. So this can be proteins like the chloride bicarbonate exchanger or subunits of the hydrogen ATPase pump. And these can be either dominant or recessive, with recessive being a more severe phenotype. Acquired causes of distal RTA often have medications as the culprit. For instance, amphotericin B can result in reversible distal RTA, and lithium can cause an incomplete distal RTA. Characteristically, this type of RTA presents with hypokalemia, as potassium is lost in the urine as a cation replacement for hydrogen. Some other key distinguishing features of distal RTA would be the presence of low citrate in the urine, which predisposes to increased precipitation of calcium in the kidney, so we get nephrocalcinosis or kidney stones. Lastly, we have our type 4 RTA, which is typically due to aldosterone deficiency or resistance. If we think back to the physiology of the RAS system, less aldosterone leads to less sodium retention, which leads to less hydrogen being excreted in the urine. It's uncommon in children and is usually due to either aldosterone deficiency or tubular resistance to the action of aldosterone, which is also called pseudohypoaldosteronism. Hyperkalemia is a key feature of this type of RTA because aldosterone is the major hormone that promotes potassium excretion. Other clinical features in children with hypoaldosteronism may include failure to thrive and hyponatremia because of the sodium loss. Hypoaldosteronism in children is more likely to be due to drugs that impair aldosterone release or function. So this includes heparin, nonsteroidal anti-inflammatory agents or NSAIDs, angiotensin inhibitors, and potassium-sparing diuretics. However, it can also be due to inherited disorders such as congenital adrenal insufficiency or genetic defects of aldosterone receptors or ENaC sodium transporter function. As a clinical pearl, when working up hyperkalemia with a normal GFR, think about type 4 RTA and pseudohypoaldosteronism. An example of a genetic syndrome causing type 4 RTA through pseudohypoaldosteronism is actually Gordon syndrome. And this syndrome can be caused by several different mutations that can lead to unregulated sodium reabsorption in the distal tubule, leading to significant hypertension. This means there's less sodium left in the filtrate when it reaches the collecting duct. This results in reduced driving force for aldosterone-mediated potassium and hydrogen ion secretion, leading to hyperkalemia and acidosis. Gordon syndrome is generally easily treated by the use of a thiazide diuretic, and that reverses the dysregulated sodium absorption in the distal tubule.